Hello, good evening, ladies and gentlemen.
Good evening, Grandpa.
Right. Today we're going to start early, not early as such because it's supposed to be starting at 7. What I want us to do is to quickly go through the session we had last Thursday because I think that there was too many disruptions from my end, and I just want us to quickly take some few minutes to go through so that by the time the rest join, we'll be done with this one and then we move on with today's event. Is that okay with you?
Yes, Grandpa.
Okay. All right. So the discussion was basically on tumesis, which I said is a normal physiological phenomenon that affect the penis. And it plays a major role because we all know that key function in the reproductive system is to reproduce. And you cannot reproduce without having sexual intercourse, at least generally, even though these days, even without having intercourse, you can still reproduce. So, but generally, normally, or naturally, you need to have sexual intercourse. And you cannot also have sexual intercourse without an erection. And as scientists, we ought to be able to understand the principles, the mechanisms, and the factors that affect erection. Once you know these things, and we move into the arena of diseases or conditions that affect the male reproductive system, of course, erectile dysfunction will come in. One of the major problems affecting men these days is about erectile dysfunction. So you should know what is erection, and then when it comes to the dysfunctioning, you'll be able to appreciate it. All right. So we said that medically, erection is called tumesis. And I also said that when you say tumesis, it generally affects, reflects a tissue which has become enlarged to some extent, not pathologically, but you've done something, either you see fluid or something for it to become enlarged. So you realize that as we move along, you see that erection has got to do with an enlargement of the penis. That's why you're using the word tumesis. And to qualify it, you have to be the erection of the penis or penile erection. Therefore, once you want to replace erection with tumesis, then it becomes penile tumesis. All right. So tumesis, as you know, is the medical terminology for erection. And we're saying that it's a normal physiological process during which the penis, one will have to enlarge, it will have to harden, it will have to become rigid or stiff. These are the characteristics of what we mean by an erect penis. And it's all about filling up of the tissues within the penis with blood. Okay. Of course, usually in response to sexual arousal, but you need to also know that it's not in all cases that erection has to be triggered by a sexual arousal. And you appreciate that you may be sleeping in the night, you wake up, your penis is on. I'm not sure it is due to sexual arousal. So in defining erection or tumesis, you don't have to restrict it to sexual arousal. All right, so that is also a point that we made. The penis ability to achieve erection is essential, as you said, for sexual functioning, because without it, you cannot have any meaningful sexual intercourse. Therefore, once it is erect, it facilitates penetrative sex. All right. Now, the return, we're also saying that the return of an erect penis to its natural flaccid state, once the penis is at rest, is said to be flaccid. All right. and that's the natural state, right? So once we are talking about erection, we should also talk about not erect, and not erect, or cessation of erection, or reversal of erection. It's called detumesis. And I try to say that when you're dealing with medical terminologies, one of the key guides is that there are certain prefixes which have certain meanings. And once you understand that meaning of that prefix, it can help you to appreciate or to understand the meaning of the medical term. All right. So then we said that DE means removal. All right. So once you say tumesis means erection, then removing the erection becomes the opposite. All right. And so that is detumesis. And the other day, a lot of you were able to mention medical terms that actually precede with the prefix D. All right. We are not going to go on any longer. And this is just a picture of a flaccid penis which is not erect, and a one which is erect. All right. Okay. So, all right. We also have to have a look at the tissues that make up the penis. We've done this already, but this is for a recap. So we said that the penis, especially the shaft, because whenever you want to have an erection, you are talking about the shaft, the body. You want the body to be hardened and elongate and to be stiff. All right. So what makes it so? What makes it so is that the erectile tissues, which we've said already, you have the corpus spongiosum and then a corpus cavernosum. The corpus cavernosum is two. So the plural of it becomes corpora cavernosa. I think we also mentioned this already. Then interestingly, we said that the corpus spongiosum actually is the one which houses the urethra. So it means that once you have the urethra within the penis, the immediate tissue to it is the spongiosum. And then after that, as you go out, you have the cavernosum, and for that matter, cavernosa, because they are two. And then after the cavernosa, still going outside, you are going to have the tunica abugenia, which is also an elastic tissue. That's also surrounded before you come to the skin itself. All right. So all those things play a role in an erection. Okay. So if you take this picture, for example, it helps you understand it a lot. So this is the urethra, and then you have this green one as the spongiosum. And then we realize straight away that the spongiosum in the glands has no cavernosa. And that's very interesting. The cavernosa is also covered with tunica abugenia. So once this place has no, I'm talking about the head here, since it has no cavernosa, then technically it also doesn't have the tunica lining. All right. And as we move along, we said that is also plays an important role, so that once we deal with erection, this place, the head here, do not become as solid or as stiff at this side, because it is the compression due to the tunica abugenia which makes the shaft area very hard. If this area should be as hard as this one, then it's going to make penetration very difficult. All right. And we said all those things. So, as an overview, the shaft of the penis, which is the body, contains three erectile tissues. Two corpus cavernosa, one is corpus cavernosum, and then one corpus spongiosum. And they all contain spaces, thousands of spaces. And we said that those spaces are called sinusoids. And we also said that the sinusoids within the spongiosum are larger than the sinusoids within the cavernosa. And we said that if that is not the case, then it means that the blood which is coming here will be very limited. All right. But also because they don't, within this side, there's very little amount of the tunica aborigina. All right. Here, there's absent. Now, if the spaces here are also small, then it will make the hardening, and for that matter, the rigidity of the erection to be very weak. So naturally, the spaces here are larger to compensate for the loss of the aborigine here. All right. So the penile anatomy, that's the structural arrangement, allows for blood to fill the sinusoids of the penile erector tissues, which when filled with blood cause the penis to enlarge, to become hard, and to get rigid. And that, of course, explains or describes erection. For those of you who have just joined, I was just saying that last Thursday there was a lot of disruptions. So we're starting early to just quickly go through what we had or what we discussed that day so that we can move on with today's main topic. That's for those who have just joined. All right. So basically how erections occurs. Penile tumesis, and for that matter, erection, is a complex physiological process involving an interplay that so many things come together. Okay, so it makes it a complex process. And technically, the things that go into it are the penile anatomy, that's the structure of the penis itself. All right, the neurovascular and the neurovasculature. And you said neurovasculature is a combination, it's combining two words. That's the nervous system, which is the neuro, and then the blood vessels, which is the vasculature. So when you say neurovasculature, you're talking about a role which is played by the nervous system and also the role played by the vascular system, the blood vessels. Okay. And of course, the associated endocrine system. And here, the endocrine system here, you're talking about the hormones that also play a role in the erection process. And of course, molecular factors like the transmitters. All of this, so we have hormones, and of course, that will be testosterone. We have the molecular factors such as the nitric acid, which is playing the role of a transmitter. We have the blood vessels, and even within the blood vessels, we have the arteries, and also you have the veins. They all play different roles to work together in coordination to achieve an erection. So sexual stimulation triggers. We are using sexual stimulation as the major stimuli here because by and large, erection by and large is mostly due to sexual stimulation. All right, but we've said that it is not in all cases that sexual stimulation may be the trigger. So in this case, where there's a sexual stimulation, it triggers the release of nitric oxide from the cavernous nerves, which initiate the erection process. So you're going to have a situation where we said that as we move along, you realize that some of the factors start from the brain. All right. So once it starts from the brain, then the brain will rather release acetylcholine. Okay. And then those ones will now impact on the nerves that supply the penis, the cavernous. When you say cavernous, of course, we're talking about the spongiosum and then the cavernosus. All right. So once you see cavernous, then you are talking about whether it is artery or veins, or once you see cavernous, you're talking about either arteries or nerves or veins that supply the smooth muscles of the penis. So take note of that. All right. So nitric oxide causes smooth muscles relaxation in the corpora cavernosa, leading to, once the muscles are relaxed, what it means is that cause virtual enlargement of the arteries, okay, because they are relaxed. So it means that the tract, and for that matter, the veins or the arteries were enlarged because the tissues have relaxed. As they relax, then they will cause more blood to now flow into it. Okay, so leading to an increased blood flow into the penile erector tissues. The influx of blood, as the blood comes in there, then the corpora cavernosa will now become enlarged because the cavernosa has spaces, and now you are having those spaces being infused with sinusoids. And now these are now being loaded with blood. And so the sinusoid become big, and automatically the cavernosa also become big. And of course, the organ itself, which is the penis, now also becomes big. That is what we are talking about. So as the cavernosa enlarges, there is compression of the subtunica venous. When you say sub, that is below, and tunica. So of course, you know, when I'm talking about tunica, you're talking about the cavernosus. So sorry, we are talking about the covering of the cavernosa. So this covering has an elastic appearance. Okay, so as the arteries are expanding, the sinusoids are also expanding, and then these are also lined by the tunica lining. Okay, so the tunica lining is serving as a pressure group, a pressure base, and so they hit it, and then it causes the arteries to expand them more. Okay, once it expands them more blood will flow in, and as they do that, what happens is that once they are now become bigger, we're talking about arteries, they will now compress or put pressure on the adjoining veins. As they push pressure on the adjoining veins, remember the veins are those that are carrying blood away. The arteries are carrying blood to the penis. In all organs, arteries carry blood to the organs, and veins carry blood from the organs. Okay, that's why the other day I jokingly asked whether you'll be able to explain if you take somebody's blood and then the blood looks not too bright red and the patient is water, what will we say? You know that veins carry deoxygenated blood. You know that because they are coming from the organs. The organs have used up whatever oxygen they carry through the arteries to the organ. So once they leave the organ, they become deoxygenated. Meanwhile, you and I know that we don't take arterial blood. Of course, there are situations where you may require arterial blood, but that is not what we use in our everyday laboratory. We use veins. So the blood that you are taking from the veins are deoxygenated blood. And it is the oxygenation or the oxygen content that makes blood bright red. So if you are taking blood and it is not too bright red, it means that it's deoxygenated. It is normal because the blood in veins are deoxygenated blood. And therefore, if you want it to be bright red, all that you need is to whale it. I mean, and then you will see that the blood is becoming more bright red. It means that you are allowing more oxygen to be absorbed by the hemoglobin, and then it is becoming oxygenated. That's all. All right. So once we come here, the veins are now being compressed. As the veins are being compressed, then it means that the volume of blood they have to take away from the penis is becoming reduced. Okay. Meanwhile, we are saying that the nitric oxide has caused the arteries to become larger, which is allowing more blood to come into the penis. At the same time, the veins, which is supposed to carry blood away, is now being occluded. So by and large, you are getting the blood to be entrapped within the penis. That is all. The entrapment or trapping of the blood in the distance is also called engorgement. And that is what causes the blood to enlarge. Sorry, what causes the penis to enlarge. So we also said the penile erection may occur not only during sexual activity, but also in other contexts, such as simple manipulation, blah, 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 right? So we are now going to take them one by one, the physiology of the penile erections. What we said was just a summary. So the physiology of it. Now, you said that the erection will occur, they will require a role by the vessels, which is the vascular. It will require a role by the nervous system. It will require a role by the erectile tissues themselves, which is the penile anatomy itself. Okay, so we are going to see how all those things play out. So we're talking, remember we talked about the neurovascular or neurovasculature. And we said the neuro side is the nervous. The vasculature side is the blood vessels. So let's take the blood vessels first, because we're talking about a situation where blood will flow in and out. So let's see how that plays out. And so the vasculature, which is the blood vessel face, right? That is what initiates erection or initiates tumescence, and can be broken down into the arterial dilation and venous occlusion. And you realize that arterial dilation is where we are talking about a situation where blood, because of the relaxation of the tissues, the arteries will dilate. And once they dilate, more blood will come in. And then at the same time, the veins will also be compressed. As they compress, then the amount of blood they have to take out become reduced. So that's also venous occlusion. So you see that the vascular role is just two ways: arterial dilation and venous occlusion. Let's see the arterial dilation. Let's have some more information about that. So during an erection, there is a relaxation of the smooth muscles within the corpora cavernosa. And we said that this is actually due to the effect of the nitric oxide. Okay, so this relaxation is largely influenced by nitric oxide, which is released by the nerves and the endothelial cells. All right, so once they relax, then the arteries, so the relaxation of the smooth muscles in the penile arteries leads to their dilation. We've said this, all right, allowing increased blood to flow into the penile chambers. All right, this is understandable. All right. So still on the arterial dilation. So the influx of blood to the penile chambers causes expansion of the sinusoids, which we've explained within the corpora cavernosa, and the arteries supplying blood to the penis will now dilate, further increasing blood flow. So there is relaxation, the arteries become enlarged or dilated, blood will flow in, and as blood flow in, the more blood flow in, the more the arteries also become larger. That's all we're talking about. So now the blood has flown into the penis, of course, into the corpora cavernosa. As the corpora cavernosa fill with blood, the emissary veins, we said that, remember we said that within the arteries, and the ones that actually supply the corpora cavernosa is the helicine arteries, and the veins that also move blood away is the emissary veins. All right. So as the corpora cavernosa fill with blood, the emissary veins that normally drain blood from the penis become compressed against the inelastic tunica albuginea. All right. So just trying to put words into what I've already described. All right. And as that happens, the corpora cavernosa is expanding due to the influx of blood. Of course, these are through the dilation of the arteries. And as they expand, they compress the veins against the tunica albuginea. So you are compressing, it's like you're compressing something against a certain wall. All right. So, and as that happens, they restrict the blood outflow. The combination of increased inflow and restricted outflow leads to trapping of the blood. I think this is also understandable. There is an increase in the flow of blood, and there is a reduction in the blood going out. That will also result in engorgement or trapping of blood, which is engorgement. All right. And this process is called veno-occlusive mechanism. Veno-occlusive mechanism. So the restricted venous outflow, which is the venous occlusion, leading to a trapping or engorgement of blood, cause a rise in pressure within the vein, within the penis, which is called intracavernosal pressure. And this is what helps to initiate an erection. Remember that you said that you got into the point where blood has been entrapped within the penis. Of course, it will increase the pressure in the penis. And remember, the blood is in the corpus cavernosa, basically. All right. So it creates what we call intracavernosal pressure. All right. I think that's also understandable. And this pressure, as you move along, which will move the penis up. All right. So this is a picture of a flaccid one. Remember, this will be the cavernosa. This is the spongiosum. They have, in the flaccid state, they have smaller spaces, which is the sinusoids. Okay. Now, with the erect one, the spaces have been enlarged, and as they enlarge, they impinge on the veins to cause venous occlusion, so that they'll be able to retain more blood within the penis. And once they retain more blood in the penis, of course, it creates an intracavernous pressure. All right, and it is this pressure that will move the penis up into the erect state. All right. So now let's also see the nervous system component. All right. Erection is regulated by autonomic nervous system, which is in the autonomic nervous system, you're talking about sympathetic and parasympathetic activities. We said that the sympathetic nervous system pathways are anti-erectile, so that once you stimulate the sympathetic pathway, erection will not take place. Even if there's an erection, it will come down. All right. While the parasympathetic nervous system pathways are pro-erectile. So once you activate the parasympathetic nervous system, you encourage or you facilitate or you induce an erection. Once you induce or stimulate the sympathetic nervous system, rather we induce detumesis. All right. That's also very important. So now let's take the sympathetic nervous system. The sympathetic pathway originates from the 11th thoracic to the 2nd lumbar spinal segment. I'm sure all of us have some understanding of the spinal cord. You realize that the spinal cord, you know the CTLS. Okay, so the CTLS is talking about the segments of, or the regions of the spinal cord. All right, so the C is, and this one is part of the mnemonics. The mnemonics, something to help you to remember. It is easy to remember CTLS. Okay, CTLS. So and these are the regions of the spinal cord. The C is the cervical portion, and then that's from the neck area coming down, and then after a point, you enter the T. The T is the thoracic region, and then L is the lumbar region, and then the S is the sacral region. The last region is not very important to me, so I normally will not consider it. So once you're able to get a CTLS, the last region is just only is just one segment, and I think the COSI is so CTLX. They go back to C. So cervical, T thoracic, L lumbar, S sacral, and then under C, that you go back to C. That's coccygeal, but the coccygeal is not so much prominent in humans, just about one. Whilst, for example, if you talk about cervical, you have the C1 up to 5 or so, and then thoracic is about 12 or so, and then you come to lumbar, I think it's about 8 or something. I've forgotten, but those are the things. So you see that when you're talking about the sympathetic pathway originating from the 11th thoracic, then what it means is that the cervical portion is free. The thoracic portion, because you're talking about CT, so from cervical, from the neck region coming down, you come to thoracic. Thoracic is 12. So you have T1, T2, T3, up to T12. It is from the 11th thoracic segment. Okay, so what it means is that if you have any effect or any injury in the cervical region or in the thoracic region up to even the 10th thoracic region, it will not going to affect an erection in any way. And even that, here we're saying that the sympathetic nervous system is what is originating from the 11th thoracic. The parasympathetic is also starting from somewhere else. So, but because you see, whether it's sympathetic or non-sympathetic, you have erection and then non-erection, erection and non-erection. So, whether sympathetic or non-sympathetic, they all combine to form what you call the erector or the erection center or the erector center. Are you following the discussion?
Yes, please.
Yeah. So from the 11th thoracic through to the 2nd lumbar, what it means is that from the 11th thoracic, as we come down, you come to the 12th thoracic, and then you come to the 1st lumbar, and then you come to the 2nd lumbar. So this is just the space that is accommodating the sympathetic nervous system. So any effect or any injury that's affecting the spinal cord outside this range may not affect your erection. I want to emphasize this because there is the popular notion that once you have a spinal cord injury, it's going to affect your erection or erectile function. It is not entirely true. Okay, it depends on, and as we move on, you see, it depends on which part of the nervous, of the spinal cord has been affected. All right. So I'm just saying that the sympathetic pathway originates from the 11th thoracic, and here you are talking about from up down. So from the up, you have the cervical. Cervical, you finish, let's see, T. So thoracic is 12. 12. So from T1 up to T10, they are all part of the upper spinal cord. All right. And then from 11 coming, so T11, from T11, you go to what? From T11, you come to what? Somebody help me. From T11, coming down.
Is it 12? Is it T12?
T12. From T12, you don't go to T13 because the thoracic section has 12 segments. So once you get to T12, I mean, you have ended. Then you come to CTL, you are starting the lumbar. Okay, so it becomes lumbar 1, lumbar 2. So sometimes you call this one the thoracolumbar because it's a combination of the thoracic section and part of the lumbar section. I hope that you get this point. And this point contains the nerves that supports detumesis. All right, because it is that section that contains sympathetic nervous system. So if you contain the sympathetic nervous system, you say that sympathetic nervous system is anti-erectile. Anti-erectile, it means that it doesn't support erection. So if it doesn't support erection, what does it support? It supports the reversal of erection, which is the detumesis. So because you have segments running from the thoracic region T11, T12 when you say T11 to from T11 to L2, what it means is that T12 is inclusive, L1 is inclusive, and L2 is also inclusive. I hope that point is clear. From this direction, it means you are dealing with T11, you are dealing with T12, you are dealing with L1, you are dealing with L2. So it's a combination of a segment of the thoracic section and a section of the lumbar. So that's why you have the lumbar, thoracic and lumbar section, and they are all for sympathetic pathway. So hello, sir.
Please, I just want to ask some quick questions before you
Yes, sir, please come.
Please, does stroke also have effect on the penile erection?
I don't know much about that, but you see, it depends on the stroke, which portion. For example, if you talk about the nerves in the cervical area, the cervical area nerves will supply, of course, the neck, your hands, and yes, I think your neck area, the head area, and then your hand. That's what I know. I didn't revise, so I don't know much. And then when you come to thoracic region, of course, the chest area and stuff like that. And then when you come to the sacral region, you remember I've said the CTLS. The sacral region is usually about the pelvic area. You know, and as we move along, you realize that the pelvic area also contains the bladder and also contains, of course, the penis and so forth and so on. So if you have an injury in the sacral region of the spinal cord, okay, it can affect the things that are in the pelvic area, including your bladder, including your penis. So that, for example, if you have incontinence, you understand incontinence?
Yes, please.
Inability to control you. So you can have urinary incontinence.
Yes, please.
What's the technical name, medical name for incontinence, urinary incontinence?
Is it frequent urination?
Eh?
Now, is it frequent urination?
No. Urinary incontinence, you are talking about inability to control. You see?
Yes,
frequency you still can control, except that the urine is coming very regularly. Okay. But you're talking about incontinence where you have no control. Before you can say Jack, and it can affect people with, like you described, with stroke, for example. That's urinary incontinence. It's called enuresis. You know, and as you move along, you talk about bedwetting. Bedwetting is what we call nocturnal enuresis.
Okay.
Nocturnal because it's happening at night. Okay, and then enuresis is just uncontrollably uncontrollable urination. Okay, so that is that. So if you ask me whether what was the question? Stroke can affect this, and I think it will depend on which nerves are involved. I don't know much about it. I'm not a clinician. I don't know much about it. What I know is that the CTLX will tell you about, and you know that nerves are controlled by the spinal cord. Okay.
Yeah.
So, and then CTLX will tell you that cervical, T is thoracic, L is lumbar, and sacral. And I said the last one, you can forget about it. All right. So, and you are moving from up to down. And so, for example, as we move along, you see that the sacral region also controls bladder. Okay, the bladder. And we also say that it's also going to, as we move along, you see that it's also controlling the parasympathetic nervous system. And you see the parasympathetic nervous system is what actually controls your erection. So anything around that area can affect your erection. So if, for example, if a clinician is working on your bladder, a surgeon is working on your bladder, and before you could say, Jack, after you finish working on the bladder and then you cannot erect because you may have severed damage some of the nerves, and the nerves of the bladder and the nerves of the penis share a common pathway. I hope that point is clear. So in working, not because the penis is close to the bladder, not that, but the nervous supply, they have a common pathway, and that is, they all originate from the sacral region, and you make few mentions on those things. So that because of that common pathway, one thing can lead to the other. And like I said, where you have full bladder, once you have full bladder, it must create an action to the brain that, oh, I have to wee. In that same area, you have the nerves also for erection. So you see that once the bladder is trying to stimulate the nerves affecting the bladder, it is also inadvertently also stimulating the nerves that also control the erection. And then straight away, you see that even though your bladder is full, the penis is also erecting. These are the things that we should know as scientists. All right. Can we move on, please? I don't know. I may not have been able to explain your question so well, but I'm saying that it depends on which area of the spinal or which of the nervous system section has been affected, and whether there's a common pathway which could also lead to another thing. Okay.
Yes, Grandpa, please. I'm grateful.
Okay. So now you see what we talk about the thoracolumbar. Thoracolumbar, we are talking about a section of the thoracic region of the lumbar system, thoracic region of the spinal cord, and also a section of the lumbar region. Okay, and you're saying that in this particular case, you are talking about T11 through to L2. And what it means here is that T12 is inclusive, L1 is also inclusive. Okay, right. And that section controls the sympathetic nervous system. The sympathetic nervous system is for erection reversal. It's for erection reversal. So it means that if that section is also severe, it's likely that you can have what we call priapism, where you can have erection and then it is not going, it's not reversing. You have it on. Okay. So we know already that activation or stimulation of the sympathetic nervous system produce contractile factors. Remember, we said that for an erection, the tissues, must it contract or must it relax? For an erection to occur, the tissues, must it contract or must it relax?
Relax.
It must relax. So if stimulation of sympathetic nervous system is producing contractile factors, will it induce an erection? Of course, no, it will not induce erection, because we want, for an erection, we want the veins to relax, or the arteries to relax. We are having a stimulation which is rather producing contractile factors, which is causing the tissues to contract. If they are contracting, then that rather they will promote the opposite of erection, which is detumensis or flaccidity. Okay. You're only going to, I thought we've done this already. I don't know why. By the way, let's move on. So the physiology, we've just mentioned about, we talked about the sympathetic effect. Now let's look at the parasympathetic. The parasympathetic pathway arises from neurons in the second, third, and fourth sacral spinal cord segments. So in this case, become what? S2 to S4. So once you say S2 to S4, then it means that we have the second, the third, and fourth. So sometimes if you don't take care, because it says S1 to S2, you think that it's just S1 and S2. Okay, sorry, S2 to S4. You think that is S2 and then the S4. So, but this one will tell you that because the S segments, I think it's about 8 or so. I've forgotten. But here you are looking at the second one, third one, and then the fourth S. All right. Don't forget, you see that here it is within the lumbar region, thoracic and lumbar region. The sympathetic is within the T11, T12, L1, and L2. And this one is completely different. The parasympathetic is in the sacral region. But a combination of the thoracolumbar portion, which you just described, and then the S1, S2, S3, S4 session, the two of them complement to give you what we call the erectile center. Because erection is about not just erect, but also about the reversal of it. Okay, so you can't talk about just erecting without talking about the reversal of it. So if you have a segment that controls the reversal of the erection, and then also a segment that controls the erection, the two of them are working together. And once they work together, then the two of them will form one center, which you call the erectile center. So if you talk about erectile center, it is you're talking about T11 to L2 and S1, so S2 to S4, something like that. Okay. So the parasympathetic nerve activation is crucial for tumescence, as their stimulation are excitatory, that is, they excite, or mostly they will use the erection, the penis to cause an erection. The parasympathetic nervous system, particularly the sacral sympathetic outflow, plays a crucial role in initiating and maintaining an erection. This is just an emphasis of the whole thing. So the erectile function of the penis is under the control of the parasympathetic nervous system. This is just recapturing the same thing. Sexual stimulation activities of the parasympathetic nerves, sexual stimulation activates the parasympathetic nerves with the following effects. One, they will reduce intracellular calcium levels. Two, they will relax the smooth musculature. Three, they will cause vasodilation. Okay, so, and this is well noted. The effects of parasympathetic nerve stimulation increases arterial blood flow into the sinusoids of the corpora cavernosa by about 20 to 40 times, causing the sinusoids to enlarge. This is just recapturing of what we said over and over again. Then so you've seen the role of the nerves, the nervous system and also the vascular system. Then let's see the role of the musculature. The penile erectile tissue, specifically the cavernous smooth musculature and the smooth muscles of the artery walls play a key role in the erectile process. The penile musculature work in coordination with the vascular system and nervous system to facilitate the complex process of penile erection. In the flaccid state, take note here, in the flaccid state, that's when it is not erect. What do you think what would be the state of the musculature, of the muscles? Yes, when the penis is not erect, it's in its natural state. What would be the nature or the state of the smooth muscles?
It to be relaxed.
No, it will not relax. If it relaxes, it will open up and then allow blood to flow, and then that will initiate erection. So in the flaccid state, that is when it is loose and hanging, which we call the pendulous state. It will be contracting. So in the flaccid state, the smooth muscles are tonical, that's the tone, are tonically contracted. So they will contract. As they contract, they will rather, it will cause the arteries to be smaller. As they are smaller, the arteries are the ones that are carrying blood to the penis. So once they have contracted, they have narrowed, and as they are narrowed, only small amount of blood will flow to the penis. And this is for allowing only a small amount of arterial flow for nutritional purposes. What we mean here is that, you see, the blood should survive. The penis should survive. without blood flow, it will also be dead. Okay, so even when there's no erection, say some amount of blood should flow into the penis to provide nourishment, to provide the kind of oxygen that the tissues also require. All right, so in the flaccid state, the muscles are tonically contracted. And this is what where the sympathetic nervous system plays a role, because the sympathetic nervous system also produces contractile factors. So those are the factors that will cause the smooth muscles to contract. And as they contract, they reduce the amount of blood flowing through the arteries to the penis. It will not block the flow outright because the penis must also survive. That's why people think that, oh, the more erection, the better. The more erection, the better. Who can explain this? I mean, the more erection, the better. Who can give us a scientific explanation to that concept? The more the erection, the better. Not for sexual, but we are talking about the fact that blood should flow into the penis for nutritional purposes.
So then that could be it. If for nutritional, that means if it is flowing more, that means more nutrient and more oxygen provision for the penis.
Okay. So you see that even in when the penis is not erect, the muscles have contracted, but they have contracted not to block blood inflow outright, because the penis needs blood. So small amount of blood will flow in there to provide that nutritional requirements. So we have also indicated that once there's erection, then the muscles will relax, and then arteries will also dilate, more blood will go. If more blood will go, then the more the better. So that it means that the more the blood flow, apart from providing the service of an erection, apart from, yes, using it for your sexual destiny, it is also giving more nourishment, more nutrition, more whatever to the penis, so that the health of the penis, which people call penile health, becomes enriched. Okay, so what it means is that when people say the more the erection, the better, what it means is that once there's more erection, there's more blood flowing into the penis, and it enriches the health of the penis. It makes the penile health stronger. That is all. So the penile musculature, the muscle, the structure of the penis, the sexual stimulation triggers release of nitric oxide. We've said this. That is the key neurotransmitter, and they are released from the cavernous nerve terminals. All right, which cause the smooth muscles to relax. So as soon as nitric acid is released, they will cause the smooth muscle to relax, and they can only be caused to release once there is sexual stimulation. Okay. The relaxation of the smooth muscles within the corpora cavernosa results in the following events. One, the dilation of the penile arteries. How does it happen? It happens because the smooth muscles have been relaxed. Once the smooth muscles are relaxed, the arteries become dilated. Once the arteries become dilated, there's increased blood flow, both in the diastolic and then the systolic phases of the smooth muscle. Remember that we said that blood will have to flow. But you see that as we have with your normal BP measurement, you have the systolic, which is where the blood pressure is higher, and then the diastolic is where the systolic measurement is up, diastolic. So for example, in one of my mnemonics, thing to help you to diastolic is WADA. So if you have the BP, one number up, one number down, then the other formula is the diastolic. Then systolic is up. All right. So Gladys, Ishak, Clement,
Okay.
put your mic off, please.
Okay,
Ishak,
sir.
Ishak. Okay. If you want to ask questions, of course, you can unmute and then ask questions. You are free to ask questions at any time. Otherwise, you mute, please. Feel free to ask any question at any time. But once you are not asking a question, please mute your mic. All right. So whether it is, and the systolic is where the thing is up, the pressure is high, and then the diastolic is once it is not, once the heart is not beating, because the heart will beat, rest a little, then that. So even at the resting phase, which is the diastolic, still more blood will be able to push into the penis. So that's why we're saying that the increased blood flow, both in the diastolic and the systolic phase of the heartbeat. Okay, right. So the events continue. The trapping of the incoming blood by the expanding sinusoids. These are all things that will happen in the muscles. And then compression of the subtunical veins. That's the veins through which the blood exits the penis. All right. So there's compression of that veins, and then the tunica albuginea and the peripheral. They all put a lot of pressure on the veins, and that will restrict venous outflow. Okay, these are all things that will happen. And then there's a stretching of the tunica to its capacity. Okay, because now the tunica is elastic to some extent. So you have to, once there's more pressure on it, it will accommodate the pressure. Then up to a point, then it can no longer go. And then that is where it is now exerting more pressure on the veins. And then once the veins, the pressure on the veins become more, then it means that only small amount of blood will flow out. So there's a decrease in the venous outflow to its minimum. And once there's that decrease outflow, then more blood will retain. As more blood retain, then it maintains the rigidity of your penis. Okay. Still on the penile musculature. And remember, you said that once blood is now engorged or retained or trapped, then it will cause intracavernous pressure. And this is supposed to be around 100 mm of mercury. Okay, 100 mm of mercury. It's very, very high. And this is enough to raise the penis from a dependent, that's the flaccid state, to the rest state. All right. Good. There's still a further pressure increase to several hundred millimeters of mercury with contraction of the ischio-cavernous muscles. There are still more muscles in the cavernous. So all of them will be, now here there's contraction. Remember with the arteries one, the cavernous one, there is what do you call it? There is relaxation. They relax to allow blood to flow in. But the other muscles around, okay, for example, above the tunica albuginea, there are still some muscles there. They will now contract to stretch, because now the tunica is also stretching. Okay, so they will contract and then produce more pressure. They will now produce more pressure. And here the pressure is supposed to be several hundreds of millimeters of mercury. And that will make the penis more rigid. So the difference between full erection and then rigid erection. Okay, so it could be erect, but maybe also sorry, but so the difference between the full erection and then rigid erection. Rigid erection is where the other muscles, apart from the cavernosa, cavernosas, apart from those, the pressure in there are other muscles attached, which will now contract and like stretching the tension within the penis, and that will now create more pressure over and above the 100 of them, and so become rigid erection. So there's a difference between full erection. Full erection is that it has erected, but so for it to become rigid erection, then other muscles should also come into play, and those muscles will rather contract. That is that. Let's look at some hemodynamics of the erection. We said this already, but just to put it into a slide. The hemodynamics of the corpus spongiosum and the glans penis are somehow different from those of the corpora cavernosa. I remember we said this, that the spongiosum has no lining of the tunica abuginea. It doesn't have it. Of course, those within the shaft has just a little. Okay. Remember we said that once that also has the tunica lining. I'm talking about the spongiosum. The spongiosum houses the urethra. And remember, we've also said that one of the things that causes the penis to be hard is the fact that the tunica abuginea is serving as a backbone, which is putting more pressure on the penis to create higher intercavernosa pressure. Okay, if you have the same thing on the spongiosum, remember the spongiosum is housing the urethra, then the spongiosum will also have bigger pressure. And once you have bigger pressure, then it can impinge on the urethra to close it virtually. So naturally, that spongiosum don't have the tunica, so that it doesn't create that kind of high tension as we have in the cavernosa region. Okay, and we have also said that when it comes to the glans penis, as for that place, there's no tunica at all, and therefore that place is rather a little bit flexible. So the blood dynamics, when we talk about hemodynamics, the blood dynamics in the spongiosum and then in the glans will be completely different from the one in the corpora cavernosa. Okay, this is so during erection, the pressure in the corpus spongiosum and glans is only about 1/3 of that found in the corpora cavernosa. All right, I think this point is well noted, and this is what accounts for the softness of the glans area as against the hardened portion of the shaft of the penis. So so here the tunica covering is thin over the corpus spongiosum in the shaft and virtually absent over the glans. So all of us know by now that spongiosum traverses the urethra within the shaft area, and then also it is the biggest tissue that forms the glans. But over there in the glans, they don't have any tunica, and therefore there is very little occlusion. And once there's very little occlusion, then there isn't going to be too much of stiffness. All right. This explains why most of the penis is hard, but the glans penis is not. All right. So we talk about the role of the hormones. The major hormone here is the testosterone, plays a crucial role in regulating various aspects of the erectile function, including nerve activity, blood vessel dilation, and smooth muscle relaxation in the penis. So all the activities that are happened, one way or the other, the testosterone plays a role. So for example, testosterone can enhance nitric acid production. And remember, you said that the nitric acid is the transmitter that actually causes the relaxation of the smooth muscles that actually initiate the process of the erection. Okay. So the hormones, and for that, testosterone is also involved in influencing the brain's response to sexual stimulation that results in erections. All right. Then our neurotransmitters. So various neurotransmitters are released and play a key role in relaxing the smooth muscles of the penile arteries and corpora cavernosa. The pre-erectile mediator, the major one, include dopamine, serotonin, acetylcholine, glutamic acid, nitric oxide, and then neuropeptide, which is oxytocin. But here, as far as the erection is concerned, we may be considering acetylcholine and then the nitric oxide. Now, let's look at the triggers. So we say that sexual stimulation triggers sympathetic inhibition. Okay, so sexual stimulation triggers sympathetic inhibition. Once it triggers sympathetic inhibition, it means that it will promote parasympathetic activity. So don't confuse the two. Once sexual stimulation triggers sympathetic inhibition, then it means that it will rather increase the parasympathetic activity. The parasympathetic activity is pro-erectile. All right. So releasing pro-erectogenic neurotransmitters from the cavernous nerves and releasing and relaxing the smooth muscles, which of course lead to the arterial dilation, increased blood flow, venous obstruction, and then automatically the erection process. We said that acetylcholine is a chemical produced by the brain that triggers the release of nitric oxide from nerve terminals. What it means is that if, as we move along, some of the triggers are just fantasies. It's like you'll be thinking in your mind the last time you had a certain affair with somebody. It's a mind game. So you trigger, you are sensitizing the brain. So the brain will now, it's rich in acetylcholine. So they will release acetylcholine, and this acetylcholine will rather go, will transmit the message that the brain is processing. Okay, that the processing is certain, the brain is processing a certain message, idea about sexualism, something. Then that will now hit on the terminals of the nervous system in the penis, and then they will release the nitric oxide. And as soon as nitric oxide is released, they will cause the arteries to relax, the tissue to relax, and then that will initiate the whole process of erectile function. So the nitric oxide acts as the principal or key physiological neurotransmitter or messenger or agent, which is responsible for the relaxation of the smooth muscle, blah, blah, blah. So all these things you've said already. Okay. And then we have a summary of all the things that we've said. I'm not going to do that again. So we have a summary of all those things, Then we come to something small on detumescence. We said that the reversal of erection is called detumescence. And It's on there. Please, am I on again? Sorry.
Yes, please,
Yes, we
Grandpa,
can
you are
hear
on.
you.
All right. So sorry for there was this call which was coming and it disrupted my network. Right. So just a little information about the reversal of erection. You can't just be talking about erection because erection without it reversing is also a medical condition. All right. So once there's erection, get to a point, it must reverse, and that's the detumescence. So let's look at what goes into the to that process. So penile detumescence, that the return of erect penis to the flaccid state, involves a decrease in blood flow and contraction of the smooth muscles. So you see that's the reverse. Initially, there's an increase in blood flow, and there is a relaxation of the smooth muscles. Once the tables turn, you are going to have a decrease in the blood flow and with a contraction of the smooth muscles. Okay. When the stimulus of erection ceases, so there's supposed to be a stimulus, whether sexual arousal or something else, whatever. If that stimulus ceases, then erection will have to subside or also reverse or cease. So the smooth muscles in the penis will contract, reducing blood flow and allowing the veins to open and drain the blood, leading to the reversal or return of the penis to its natural hanging, soft, flaccid state. So this is also very simple. It's very, very simple. You don't have to waste time on that. And this one to emphasize that penile detumescence is primarily controlled by sympathetic nervous system. The other one is sympathetic. This one, the parasympathetic controls erection, but the detumescence is primarily controlled by the sympathetic nervous system. So a shift from parasympathetic activity, which promotes erection, to sympathetic activity, which promotes detumescence, cause a decreased blood flow to the penis and increased blood flow, outflow, for the penis, leading to the return to the flaccid. What it means is that now the blood which is coming in will decrease, and the blood which is going out will also increase. And that will reverse the whole process that actually causes an erection. It's very, very, very simple. Now, so the processes can be put into 3 phases. The first phase is that there's an initial phase, which is characterized by reduced parasympathetic activity. So because we say that once we have an increased parasympathetic activity, that induces or facilitates erection. So for it to reverse, then the parasympathetic activity stimulus should reduce. So there's reduced parasympathetic activity, which leads to the cessation or decrease in the initial parasympathetic signal. Okay, leading to a reduction in the release of vasodilation substances. So it is very simple that now your sexual stimulus is no more. All right. So there's the sexual stimulus which will promote or stimulate production of increased amount of parasympathetic activity. Once it's no more, that stimulus is no longer available. So the parasympathetic activity will reduce. Okay. And then once that reduces, we are expecting that the vasodilation will also be constricted. So it means that the factors or substances which are causing the vasodilation should also reduce. Okay, so as simple as that. So the second phase shows an increased sympathetic activity. Remember that we said that sympathetic activity promotes detumescence. So if already there was a parasympathetic activity, which was causing the erection, and now that is going down. Once that is going down, then there must be an increase in the sympathetic activity. Okay, as simple as that. All right. And so the third phase is where now there's an increased venous outflow. More blood is now leaving the penis. Okay, once more blood is leaving the penis, then, but of course, it will not reduce to the point that there's no blood in the penis. That is a point to note. I think we can read about this one. It is also the detumescence. Once it is also triggered in, what happens is that the intracavernous pressure will also reduce. Okay, very, very simple. Then while nitric oxide, the neurotransmitter which promotes the realization for erection, other neurotransmitters are also responsible for detumescence, and they include the endothelin and neuropeptide Y. Okay, they also be released to listen. So that is very simple, and these are pictures for you to help you. So this is just a review, or yes, more or less a recap of what we did on Thursday. I did this because I felt that last Thursday there were a lot of breaks and the information didn't go well. And from what I gather, it appears some of the things that I said now appear to be even new to some of you. I don't know why, but I get a sense that you are seeing it as a new session. All right. So now it's a continuation. It's a continuation. So now you've done extensively with erection and of course detumescence, how it happens, the role played by the anatomy of the penis is about the structure, the musculature. We've seen the role played by the vasculature, which is the arteries and then the veins. Arteries bringing in blood, veins taking out the blood. There are individual roles. You've seen the role of the neurons, the nervous system. We've seen the fact that the parasympathetic nervous system is the one which controls erection, and then the sympathetic rather also promotes detumescence. All right. So now let's look at the types of erection that we have. The penile erections can be broadly classified into three main types: reflexogenic, sarcogenic, and nocturnal erections. So just the name itself will give you an idea about where they are coming from. Reflexogenic, of course, reflex action. And what comes to mind when you're dealing with reflex action? When you say reflex action, what comes to mind? Hello? Anybody? This is not connected with direction. We talk about reflex action, the reflex act. What comes to mind?
It's an unintentional thing.
Maybe a response to a touch or something.
Okay. Any other? I will mention names, so if you don't talk.
It's like an unintentional something.
Unintentional. I'll give you 2 over 10.
No.
Yes. If you talk about reflex action, what comes to mind? You want me to mention names? Ishak. Ishak, your phone is always on. your mic is always on. So Ishak, now talk. Ishak, if you talk about reflex action, what are you talking about?
Grandpa,
Right. Something to bend back.
No.
Grandpa,
Yes.
I think it's involuntary responses.
Involuntary. That is it.
Mm.
And you see, in that case, you can't control it. So it's uncontrolled action. Before you could say, do you control how you what do you call it? Your the eye, the way it blinks. Do you
Blinking
control
of
it?
the eye.
The blinking of the eye, do you control it? You can control
No.
it. Yeah, it's a reflex action. So so that is that. So there's reflexogenic action, that is things that can happen without you even controlling. You have no idea how it works. Okay, you can't control it. Then psychogenic, of course, coming from the mind. Okay, and that will straight away talking about thoughts. Sometimes you think about your girlfriend or some girl that you say, yeah, the thought of it can give you. We are going to look at this ones one by one, but just even on the face of it, psychogenic, about the mind. You'll be there, you are imagining the last time you met a certain girl and or something. So psychologically, you get an erection. Now, nocturnal, of course, in the night, you also, that's also another thing you talk a lot, nocturnal erections, where you wake up in the morning and then the penis is up. Why? And the morning erection is also considered as part of the nocturnal, because we will deal with it one by one, but I'll just give you some gist about it. So once you get there, I can just move fast. Nocturnal erection, is about night. Okay, nocturnal, night. Erection happening in the night. Then you know that the sleep pattern occurs in phases. The other day I mentioned it, that we have the N1, N2, N3, and then the REM phases of the sleep cycle. So you see that you sleep, and at a certain point, somebody touch you, then you wake up. Okay. At the same time, sometimes you sleep at the same time. You sleep, somebody will touch you, even if the person is even beating you, you can't you don't even know what you are doing. You can't wake up. And then within that same period, now at a point, the person will just even cough, and then you wake up. Okay. So what happens is that in the night, as you sleep, the brain goes through this cycle, which you call N1, N2, N3. So at N1 is where, as if you want to sleep, as if you don't want to sleep, it's like you're dozing off. That's N1. You are just about to sleep. At that point, any small thing, you wake up again. You are just about to sleep. Yes, the dozing off stage. And then after that stage, there's this N2. That's a very light sleep. So after that stage, it's also easy to also wake up to some extent. All right. But it is not as easy as the N1. As for the N1, it's like as if you are sleeping, you are not sleeping. But the N2, you are sleeping, but light sleep. Okay, the N3 is deep sleep. You are actually sleeping. Okay, and then you don't go from N3. N3 is what we describe as the deep sleep. We don't have N4. We have a REM, rapid eye movements phase. That is where you dream. That's where you dream. So in N1, N2, N3, there's no dreaming. But the REM, you dream. And then after the REM, that's the rapid eye movement phase of the sleep cycle. You go back to the the N1. So what it means is that after the REM, you get to a phase where like you are sleeping, you are not sleeping. Okay. So by the time you wake up, In fact, in the REM stage, you may not be able to wake up unless somebody pushes you hard. But from the REM, remember you are coming to where? From REM, where are you going to?
M1.
From REM, where are you going to?
N1.
N1, you're coming to N1, and that stage you can easily wake up. So to be able to wake up in the morning, what stage are you coming from?
You are coming back from the REM.
We are coming from the REM, and REM is where you are going to have dreams. Okay. And since you are coming from REM, as you move along, nocturnal erection occurs within the REM. So by the time you wake up, straight away, you are coming from an REM to an N1, where you are going to get up. So since erection also happens in the REM stage, you wake up with an erection. Is that okay?
Yes, please.
So that's how come morning erection is also captured as part of the nocturnal erection. So take note, you do all those things extensively. But what we're saying here is that erection in the morning, which you call morning erection, is captured as part of nocturnal erection because it is happening within the time that you are in the last phase of your cycle, which is in the REM stage. Because in the REM stage, you cannot wake up. So to be able to wake up, it means you've gotten back to the N1. And to get back to N1, it means that you are just coming from REM phase. It's the REM phase where dreaming occurs and also erection also occurs. So since you are coming right from, erection can take place for, let's say, 15 minutes or even 20 minutes. So if you wake up, you still can enjoy your erection whilst you have waked up for another 10 or 15 minutes before and remember, once you wake up, which nervous activity will dominate once you wake up? Sympathetic activity. Do you remember? Because
yes, please.
See, parasympathetic activity will cause you to rest. You see, parasympathetic activity will cause you to rest and sleep. Sympathetic activity is what people call the flight, free on flight or something. I mean, it's like there's an activity. So, and sympathetic activity will cause detumescence. So once you wake up, the sympathetic activity will now predominate. And once it predominates, it will now have to suppress the parasympathetic activity. So once you wake up, automatically, within a short time, sympathetic activity will become dominant. And that will now lead to detumescence. And the erection will reverse. So I want you to appreciate the science behind the everyday things that we see. The science behind it. That's all. That's the basis of andrology. The science behind the everyday things that we experience as far as the male reproductive system is concerned. Even if you are a female, of course, you are all mature people, you have husbands, you have children, male children. So once, don't say that, oh, but I'm a woman, why am I, why should this thing even concern me? It should concern you because you have a husband, you also have male children. And even as we move along, you see that there is, remember we talked about the penis clitoris homology. Do you remember?
Yes, please.
Yes. So it means that the clitoris is also like the penis. So if the penis will erect, what do you think will happen to the clitoris? The clitoris is also erect. So we also have a female nocturnal. In the female, you also have nocturnal clitoral erection. We will mention those things. So don't think that because you're a female, this thing, why should this thing? You have to, especially because you're a scientist. All right. So whether it is reflexogenic, psychogenic, or nocturnal, the classification is based on the stimuli that trigger them and the pathways involved in their generation. I think that point is clear. Good. Reflexogenic erections and psychogenic erections may not be mutually exclusive. When it says something may not be mutual, when they say mutually exclusive, it means that this one will happen on its own, this one to happen on its own. When they say they are not mutually exclusive, it means that you can still have this and still have that. This means that sarcogenic erection might be triggered while someone is already experienced a reflexogenic erection. Okay, so the two can happen at the same time. As for the total erection, it's a different principle. We're talking about reflexogenic and sarcogenic because we say that there are three classes. Don't think that, oh, this is separate, this is separate, this is separate. No. They are not mutually exclusive. So you may be having a sarcogenic or reflexogenic erection, and meanwhile still have a sarcogenic stimulus that will rather even strengthen your erectile function. All right. So reflexogenic or reflexive erection is produced or triggered by direct tactile stimulation. Tactile here, we're talking about, but tactile means touch. So when you say that erection which is stimulated or which is induced, which is produced by touch. But tactile is not just an ordinary touch. It is a touch that appears soft, warm, and gentle, pleasant touch. This is what we're talking about, because you can't touch my scrotum and squeeze it and say that it's tactile touch. No. Tactile, so we are defining tactile stimulation as those ones that include soft, warm, gentle, and pleasant touch. That point is clear. Tactile just simply means touch. So you can't say tactile touch, for example, because tactile is a touch. But we want to describe the kind of touch that we're talking about when we are dealing with tactile. So tactile is not just a touch where you can grab something and say, I'm touching you. All right, so this is the thinking behind it. So tactile stimulation, a soft touch, a warm touch, a gentle, a pleasant touch. That is what will stimulate the body and not a hard touch. And we say that tactile stimulation can also influence the heart rate, breathing, and other vital signs, including your penis. Remember, once you have something that can also influence your heart rate, it can also provide some impetus for erection. All right, you see a lady and there you see that your heart is beating, and before you could say Jack, you have erected. Once your heart is beating, it means that you are increasing your blood outflow from the heart, and which means that you are giving more supplies to all organs, of course, including the penis. And remember, we say that the whole mechanism of erection is about influx of blood. So if something is happening to the extent that there's increase of blood into the penis, of course it will erect. All right. Now, sometimes people describe the reflexogenic because reflexogenic got to do with touch or tactile. Sometimes it's called contact stimulated or touch stimulated. But remember, we say that the contact or touch is the tactile type, the one which is soft, smooth, gentle, and pleasant. Okay, so we can have what we call contact stimulated erection or touch stimulated erection. It's the same thing as the reflexogenic. They involve a direct tactile stimuli to specific areas of the body. And specific areas of the body, those areas which we classify as reflexogenic zone or receptive field. Those are the areas when you touch gives that kind of sexual stimulation. I hope you are following me, because not any area that you touch which will stimulate the body. For example, if you stimulate my neck, I'm not sure that it's going to arouse me. But if you stimulate my I don't know. So we have what we call the reflexogenic zone. Reflexogenic, those areas when you touch that the body will respond. Okay, so of course, if you touch somebody's genital organ, of course, by all means. If you touch my leg, I don't think so. It's not. So if you are touching areas that can reflect in or that can induce an erection. And those areas, all those areas collectively are called referencogenic zone. Okay, so if you have a partner, you may want to know the referencogenic zone. Some people, some ladies, if you touch their ears, becomes sensitive to them. Some, if you touch their nose, some, if you touch, of course, the clitoris, if you touch their arm. So all those areas that can respond are called referencogenic zones or receptive field. All right. So the reflexogenic erection that we are saying that here the impulses with the spinal erection centers. Remember, you talk about the spinal erection centers as the T11 to L2. And we said that when you say T11, it means that it also includes T12. And since the thoracic segment has, the thoracic region of the spinal cord has 12 segments, after T11, you go to T12. And then from T12, you have the CTL. So then you are entering the L region, which is the lumbar region. And once you have L2 here, it means that L1 is also inclusive. So it becomes T11, T12, L1, and L2. Remember, we said that that part controls the sympathetic nervous system. And then S2 to S4. So S2 to S4 means that it includes S2, S3, and S4. This is the sacral region. And that also controls the parasympathetic nervous system. So you must know these things. So the impulses after the touch, the impulses will reach these regions. Okay, so it means that they will not go to the brain. So note that here the impulse is picked. If you touch me, then the impulse will go to will carry through to the erection centers, the spinal erection centers. The messages are sent via the cavernous nervous system to the penis to induce an erection. Okay, so here you are not talking about the brain. Okay, you're not talking about the brain. You have a touch stimulated a touch stimuli, and then to pick up to the spinal erection centers. Okay, and then from there, the nervous system will also respond. Okay, by telling the cavernous nerves to produce what will the cavernous nerves produce? They will produce nitric oxide. Okay, and then that will now also initiate erection. Okay. The penile nerves responsible for receiving signals of touch originate from we've said this already. And then the chain ganglia from T11 to L12 supplies this, but we've said this already. So here, the brain plays no role. The brain plays no role. Once you touch me and blah, 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 the brain is not thinking. I mean, once you touch me, no, it's an involuntary action. That's why it is reflexogenic. Okay, right. So in men with spinal cord injury, the erectile function depends largely on the nature, location, and extent of the spinal cord. The nerves that control reflective erection are located in the sacral nerves S2. We said all these things. This explains why reflexogenic erection is preserved in patients with upper spinal cord injury. I think we've said this already. So once it is reflexogenic erection is controlled within the S2, S4 region, then anything happening in the upper spinal cord will not affect the erection. This is also something we've shared already. The bladder and penis share common nerve pathways, specifically the sacral nerves S2 to S4. So a full bladder can stimulate nerves that control erections. I think this one we've said over and over again. A full bladder can now stimulate nerves in the same region of the spinal cord that control penile erections. This explains the possibility of a full bladder causing reflexogenic penile thymosis. I hope that point is also well noted, so that if you have your, especially our ladies, if you have a small boy and then you see that the penis he has erection, I mean, you shouldn't think that he has seen a woman or apart from the night one. You're talking about the day where you see the penis erect. You should have a feel that the small boy want to leave me. All right. Just because once your bladder is full, to send a signal to the spinal cord area, which controls the urination. Meanwhile, it is the same region which also accommodates the erection nerves. All right. So as simple as that. So, but take note of this one. Unlike physiological penile thymosis, sleep-related erections tend to inhibit urination, thereby helping to avoid nocturnal enuresis, which is bedwetting. What it means here is that, you see, we're saying that if you have a full bladder, you can result in erection. Okay. Now, if in the night you have a full bladder, okay, and then you also have an erection as a result of what you describe as nocturnal thymosis, what will happen? It means that since full bladder can cause an erection, then it appears that the other way to will show that if you also have an erection, your full bladder should begin to empty. But rather, it has been noted that once you have an erection, it will rather block any tendency for urination. Okay. Otherwise, in the night, since you have penile erection in night, which is also involuntary, then it means that you can also wee, and then that would be nocturnal enuresis. But you see that nocturnal enuresis, even though it happens in children, but in adults, it doesn't happen. Okay, what it means is that, yes, if you have full bladder, it can trigger an erection. But the reverse is not true, that if you have an erection, you can also have full bladder. Okay. Rather, if you have an erection, it will cause, even if you have a full bladder, it will cause it, to inhibit its attempt for urination. I'm hoping that you are following the discussion. All right. And so that's how come nocturnal enuresis, which is bedwetting, is prevented. But, you know, especially if children, at least between 3 to 5 years, it's supposed to be normal. But if you have a child, after 5 years, you still have 5 years, 7 years, you still have nocturnal enuresis. I think it becomes a medical condition. You may have to report for this. So nocturnal enuresis, which is the bedwetting, may be considered to be normal if the child is up to 5 years. Okay. But if after 5 years, 6 years, 7 years, please, it has to be considered as a medical condition, and then you have to do something about it. So that's not a nocturnal enuresis. And we said that is also urinary incontinence. Okay. But there's difference between urinary incontinence. Urinary incontinence, it doesn't matter whether it's night or day, you can't control your urine. And you see that you may have to put, even if you're an adult, you may have to put on Pampers. That's urinary incontinence. But nocturnal enuresis is where in the night, before you could say Jack, you have wet your bed. That's the bed wet. The English, the normal terminology is wet bedding, but medical terminology is nocturnal enuresis. Good. So now let's look at, so that is psychogenic, reflexogenic, where it's a reflex action, you have no control. Psychogenic is the mind which is processing something. So let's look at the psychogenic erection. It occurs without concurrent tactile or physical touch stimulation. Remember, I said that tactile is a touch, physically touching. All right. And you also said that tactile is not just an ordinary physical touch, but it's a touch with a difference. I think the ladies can understand better. You see that the touch there, you will feel it. You will feel it that yes, this touch there, it is sexually use. Just by the way. So you have the psychogeneration is as a result of audiovisual sexual stimulation, which we call AVSS, audiovisual sexual stimulation. What it means is audiovisual, all of us know audiovisual is like you are watching and also hearing. Watching, it's like a video of a sort. Okay, so, but the video is erotic. It's like what people call pornography. Okay, so you are audiovisual sexual stimulation. You are not touching anybody. You're only watching and listening to what is going on, and then straight away you get stimulated. Okay. That is psychogenic erection, and the stimulus is audiovisual. Okay. Now you also have fantasies where you are imagining a fantasy. You are just, but it is related to erotic visual thoughts. It's like you are, it's not, I don't know how to put it, but audiovisual is when you are watching a video and listening to it, that is stimulating you. But with fantasy, you are talking about, you are just being imaginative. Sorry, this call that was coming. Sorry. So, talk about AVSS, which is the audiovisual sexual stimulation. That one, watching a video with sexual connotations, sexual content. That is it, which a lot of us call the pornography. Fantasy, you are not watching anything, but you are only being imaginative. You are imagining something which also have sexual content. Okay, I think that one is different. That one is like you're only thinking, hey, the day I met this person, the way blah blah, the way he touched me and blah blah blah, all those things. But it's not a physical touch. You are not watching anything. So you are just having these thoughts, and they are all imaginative. You also have some other sensory stimulative, which we call olfactory. The olfactory stimulation, olfactory has got to do with what? Smell. Sometimes you see, especially some of the ladies, they have means of attracting men. Okay, they will put on certain spray, and you yourself straight away that spray will attract you, and before you could say Jack, no, you are the erection has taken place. That is olfactory stimulus, and olfactory got to do with smell or sense. Okay, olfactory stimulus, stimulation to your olfactory organs, and that is smell, the nose. You can smell of a certain how do you call it? Especially some sprays are so said that once you smell it, you get a certain feeling. Okay, all right. It's not for everybody. It's not everybody's. Even with the audiovisual, somebody will watch a typical pornography and it won't do anything to the person. Somebody will also be thinking about something to do. So these are relative. Some people can watch all these things. or you can touch this person anyway and it will not happen. It doesn't mean that the person is impotent. No, it's just that because this got to do with the mind. The thing that you see is not allowing the mind to process it. Okay, it's not thinking about it. All right, so that's so the olfactory. Then we have the gustatory stimulus. It's got to do with taste. You see, this is relating to the use of taste, including mindful exploration of the taste of your partner's skin during kissing or force with sensual or evocative love. What you see, some people can be funny, right? Even if you kiss a lady, the taste of the mouth itself can be lingering on for a long time. Anytime he remembers the way he kissed that lady, it's like not the visual aspect, but it's like you kiss and you get a certain feeling in your mouth that, hey, wow. Then that kind of taste can linger on. Anytime you remember it, then you also begin to be aroused. These things can happen. Some people can act weirdly. And as scientists, you should know all these things. Okay. Certain, like I said, see, you are talking about foods with sensual or evocative flavors. Some people have a means of, let's say you visit a certain partner, the kind of food that will give you, the taste itself, once you're eating, you begin to be aroused. I'm told that some ladies have a means of preparing certain foods to the extent that the taste will linger on your mouth for the rest of your life. Anytime you remember it, you get aroused. I don't know. I haven't experienced some before, but that's what I've heard. All right. Other fantasy stimuli which can trigger the brain to initiate the erection process include auditory stimulation. This is very, very common. See, and here we're thinking about fantasy stimulation. Fantasy stimulation is about imagination. You are imagining it. All right. So if the imagination is through the ear, then that is auditory stimulation. All right. So you can pass behind somebody's house when you have some bad boys. They will pass behind somebody's house and then they will hear something going on. Some sound which is creating the impression that some sexual activity is going on. Then they will be standing at the back and then they will erect. And so this is common, very, very common. And you hear moaning, you see that you yourself, you may have had a sexual encounter with somebody, and then the way he was, anytime you remember that in the then you yourself will get erection. Nadia, are you there? Hello? Is my class rep there? Can you hear me, please?
Hello, Grandpa, please, I'm here. I can hear you. Sorry.
Oh, okay.
Yeah.
I was saying something funny. I wanted you to laugh more, and you are
Small. Okay.
So what I'm saying is that we have
Okay.
various fantasy stimulation. Fantasy is about imagining, thinking.
Yes, please.
So you can have the way your partner, and this, of course, we are dealing with erection, so it's not about you, but I'm talking about the men. When
Okay.
you always remember some sweet words a certain lady spoke into your ears, and then
Yep.
that straight away you begin to you get aroused. All right. So
Yes.
these are auditory stimulations.
Okay.
Sometimes you hear a certain music. That music straight away gives you that kind of
Yeah, bring back the memories, kind
that,
of.
yeah, that's good. So and all those things. So you should know that what group, how do you categorize this? This one goes into auditory stimulation. Of course, they all come under sarcogenic erections. All right.
Okay.
All right. What happens is that as you talk about this stimuli, then the brain processes these erotic stimuli. Impulses are sent from the brain to the spinal erection centers, of course, the T11 to, as you say, and then to activate the erectile process. So here you're talking about the brain, which is at work. And many of them are fantasies. Many of them are imaginative. It can be auditory, it can be gustatory, it can be whatever. All right. So individuals with sacral spinal cord injury retain sarcogenic irritability, even though reflexogenic erection is abolished. You see, remember you said that with the reflexogenic, the whole thing is happening it's a reflex action. It's all happening within the nerves. The brain is not included. All right. So whenever there's sacral spinal cord injury, remember you said that when there's spinal cord injury, you should have an idea which part is affected. If the spinal area, then it means that that's the side that erection center is located, and therefore it's likely to affect an erection. But remember, we said that erection we have categories. All right, so the one which is within the sacral region is actually the ones which is reflexogenic. That's the reflex action type. So if there's an injury here, then reflexogenic erection will be compromised. But if it's sarcogenic, if it's something we are thinking about, then that one too, the spinal cord area will also be it's like it doesn't come in here, and therefore you have your erection capabilities restored. These are the things that you must know. So if you have spinal cord injury, assuming that that doesn't rule out the fact that you can also get erection, because you can now also rely on your sarcogenic erectile capabilities, where now it is the brain which is working. It means that here you are thinking about, it's not about touch, because here, when you have spinal cord in the sacral region area, even if the person touch you, that area is compromised. So it will not work. But if you're talking about the mind, even though you have a spinal cord injury, your mind is still working. Okay, so you think about some old things about your listening, and then the mind can also process it and still give you an erection. So I just want us to also appreciate the fact that spinal cord injuries many times have been considered as an effect that can give you erectile dysfunction. It may be true, it may not be true. And these are some of the things that I want us to consider. All right, so we will do a little bit of the nocturnal erector, pinna erector, listen, nocturnal erections. That's the nocturnal pinna tumensis. Do a little bit of it, and then we can continue tomorrow. All right. Nocturnal erections, as we said, is also excuse me. Nocturnal erections are erections that occur in the night, as simple as that. Also known as nocturnal pinna tumensis. You understand the word nocturnal, you also understand tumensis. So you understand it's the same thing. Or sleep-related erection. Sleep, SRE, sleep-related erection. Or morning wood. Morning wood, because that is a jargon. Rather, people want to call it morning erection. All right, but you have to know all this because it depends on who is talking to you and how when you meet something, you know that, oh, this words can be used interchangeably. Okay, so nocturnal erections or nocturnal pinna erections or sleep-related erections or morning erections or morning wood, they are one and the same thing. Okay, they are spontaneous and involuntary penile erections that occur during the night while asleep or upon waking up. And I'll explain why when we wake up, the erection there is still considered as part of the nocturnal erection, because we said that the erection norm, as we move along, you see that it occurs within the REM phase of your sleep. And after REM phase, you come to your senses of whether to wake up or not to wake up. So once you decide to wake up, it means that you are coming from the REM, and to the REM phase that produces an erection. And therefore, it is also sensible to include what you are seeing in the morning as part of what happened in the night. That's how come morning erection becomes part of the nocturnal penile tumensis. All right. And they are not associated with sexual arousal or desire or dreams or thoughts with erotic content. All right. So this is a normal physiological phenomenon. The nocturnal penile tumensis is a normal physiological phenomenon. It is not related to the fact that otherwise, if you don't take care, you have your small boy who wakes up and the penis is up, and then you begin to beat the this small boy, you're experiencing erection. It means you are thinking about a certain lady or something, or you saw something. It is not true. They are part of normal physiological phenomena. And as we move along, you see that they occur several times during the night. These erections are naturally occurring physiological phenomena during the REM sleep in all normal healthy males. So if it doesn't happen, it means that there is something wrong with you as a man. So that's why I say they occur during the REM sleep in all normal healthy males. In fact, they occur from infancy to old age. All right, let's see the next line. This is interesting. In these sleep-related erections, that's the nocturnal, the sleep-related erections have been reported to occur even in intrauterine life. That is, even with the unborn baby in the womb, the penis was still erect. And it is, as scientists, you have to get this information or this knowledge. Otherwise, see, our friend cried, Tama, or that mammy and crying, and what happened between so obey German for pa. It is a normal, natural, physiological phenomenon. All right. NPT, which is the nocturnal penile tumensis, of course, nocturnal erection, typically occur during the rapid eye movement REM stage of sleep, the phase during which vivid dreaming occur. I think I've explained this already, that within the sleep cycle, you have N1, N2, N3, and then the REM. It is within the REM phase that dreaming occurs. Okay, at this stage, that the nocturnal erection also occurs. As we move along, you see what happens and why that happens. Right. Normally, there are 3 to 5 erectile episodes per night, each lasting 10 to 25 minutes, and typically resolves within minutes of waking up. So we're saying that there must be between 3 to 5 episodes of erection in the night. You see that because all of them you may be sleeping, even from REM to N1, you may not wake up. So the sleeping, you see that as if you want to sleep, as if you want to wake up, but you won't wake up. You won't even open your eyes. Then the sleep will come again. So that will happen. In fact, depend on how long your night, for how long you sleep. Each cycle will take around 90 minutes to 120 minutes. 120 minutes is about close to 2 hours. Yes. So each sleep cycle will go through that period. Okay. So even if it's 90 minutes, which is 1.5 hours. So every 1.5 hours, you'll have gone through that phase. And then you continue. So if you are sleeping for about 8 hours, then you know that the sleep cycle will go about 6 times because minimum 90 minutes, which is about 1.5 hours. And assuming that you sleep for 8 hours, it means that you go through the cycle about 6 times, isn't it? Huh. So if you're going through the cycle 6 times, you go through an REM 6 times. And if each of the REM you are getting an erection, then it means that you can have nocturnal erection about 6 times within one. But these days, a lot of us don't spend that much time sleeping. Sometimes some people sleep around even 12 midnight and they wake up at 4. So it means that they have slept for just about 4 hours. If they have slept for 4 hours, it means that their sleep cycle will go about 2, maximum 2 or 3. Okay, it will not even go more than 3. Okay, so because people don't sleep for long, they don't go through the sleep cycle the way it is expected. I'm sure you are following the discussion that it is expected that you will spend about 8 hours sleeping. If you are spending about 8 hours sleeping and each sleep cycle takes you about 1.5 hours, then it means that you go through about 6 cycles before you sleep, before you finally wake up. But here you are, people sleeping around 12 midnight, waking up at 4, spending 4 hours. So how many sleep cycles would they enjoy? Just about 2. So if they're just about 2, then it means that, and it's not every cycle that can also give you, every cycle you have an REM, but it's not every cycle that can give you an erection. Okay, so if you spend just only 2 cycles and none happens, no erection happens within, that doesn't mean that you are getting, because you are going to get to a point where we say that if you are not experiencing any MPT, then it is a sign that you are having erectile dysfunction. But I'm just giving you this other interpretation that because people don't spend too much time sleeping, then the possibility of also missing the MPT is also high. And if you don't take care, people will be reporting for erectile dysfunction based on the fact that they are not seeing any nocturnal penile tumensis as if they have a problem. So I want you to take note on that. All right. Very good. In females or female counterpart, there is the nocturnal clitoral erection, because we said that the erection, sorry, the penis and then the clitoris have a lot of commonalities, which we describe as the penile clitoral homology, a lot of commonalities. And they also have the erectile functions. So the erectile tissues, they also have it. The cavernosus, they also have it. And so it means that what happens in the penis can also happen in the clitoris. And so it is also possible for the clitoris also to erect. And once that happens, it gives them a feeling of enjoyment, sexual enjoyment. If you are with a lady and is touching you at that moment, you see that, oh, is also having a desire to have a shot, and then you give it to her. Okay, so its female counterpart, I'm talking about the nocturnal penile tumensis, its female counterpart is the nocturnal clitoral erection, where pulses of blood flow in the vagina during the REM sleep to achieve clitoral erection cycles, and the vaginal engorgement in women during the REM sleep. So it is the same thing that happens in the men. Okay, and this slide just emphasizes the fact that the clitoris can also erect. And just as you have nocturnal penile erection or nocturnal penile tumensis, they also have nocturnal clitoral tumensis. Now we will end very soon here. So nocturnal penile tumensis, the physiology is that during the REM sleep, certain areas in the brain responsible for stimulating the parasympathetic nerves. And here with the parasympathetic nerves, you're talking about rest and digest nerves. The resting, because the parasympathetic nerves cause you to sleep or cause you to relax. Okay. So in the night, the brain will activate that session. Automatically, the brain will activate a session that stimulates parasympathetic nerves. Okay. While suppressing, so you see that while the parasympathetic nerves are being activated or stimulated, of course, they must suppress the sympathetic nerves for you to be able to sleep. Sympathetic nerves are for flight and fight. That is where it makes you energetic. But in the night, that element of flight and fight should be suppressed. Okay. So you see that in the night, in the day, in the day, which of the nerves are activated in the day, please?
The sympathetic.
The sympathetic. Which of the nerves are activated in the night?
The parasympathetic.
Yes.
Good. So you see that the parasympathetic promotes erection. So once you sleep during the REM phase, the body is going to a state where you have virtually suppressed every activity of the sympathetic nerves. Okay. And then the parasympathetic nerves have been activated. Parasympathetic, so there's a shift from sympathetic nerve to parasympathetic nerve. So, of course, that shift in the nervous system will now trigger erectile function. I hope that one is clear. So in the night, whilst you are asleep, during the REM stage, the what you call the rapid eye movements phase of your sleep, that's where dreaming occurs. The brain now is able to make sure that there's no activity of the sympathetic nerves. Okay, there's no activity at all, but rather it promotes a lot of the parasympathetic nerves. So once that happens, then it means that it's also triggering what do you call it? It's also triggering stimulus for an erection to take place. So that is all. So that is all. It has been noted that no section, no phase of the sleep cycle where erection takes place. So your N1, N2, and N3, each of these stages, erection will not take place. Erection will take place only in the REM phase because the REM phase you have enough activity of the sympathetic stimulation. Okay. And sympathetic stimulation is what got the process for erection. And this is very, very important for me. And we said that for normal sleep, you have about, let's say, 3 to 5 sleep cycles. You have 3 REMs, and each of the pathetic Hello, can you hear me, please?
Yes, please, Grandpa. You just came back on.
Okay. We have my network, my slash share has dropped. I don't know whether you are still seeing it. So we continue tomorrow from where we left off. Any question, please?
Grandpa,
Please, any question
hello,
on what
Grandpa.
so far?
Please, regarding
Yes,
to
sir.
the
Yes, sir.
nocturnal erection, is it possible someone with low sperm counts to experience the nocturnal erection dysfunction? Hello.
Come again, please.
Please, I said
Yes, sir. Your line was
regarding
breaking,
to the
so I couldn't hear you properly.
my network is not stable. Yeah, my network is disturbing. That's why I said regarding to the nocturnal erection. So someone with a low sperm count,
Yeah.
is it possible the person will experience the nocturnal erection dysfunction?
Okay. The low strength count is on a different tangent.
Okay.
I'm saying low sperm count has nothing to do with the nocturnal penile tumensis.
Okay.
Can you hear me? It has nothing to do.
Yeah, I can hear you. Oh, okay.
So
because like someone was saying usually that
as we move on, another as we move along, you see that the nocturnal penile tumensis physiology. I mean, the erection physiology, everything is normal. That's all. Okay.
Okay.
But that move on, you're going to deal with ejaculation, and there are a lot of difference between ejaculation and erection. Okay, and it's also got to do. It also has differences with the way sperms are produced, because you can ejaculate and there are no sperms. Okay. So the amount of sperm that you produce has nothing to do with the ejaculation. It has also nothing to do with the erection. Okay. So all that we are saying is that erection at night is a normal, natural physiological phenomenon, which has nothing to do with somebody because you are sleeping and then you are thinking about a certain woman or something. That's why, no, it has nothing to do with sexual arousal. So we just want to make this point so that if especially the kids, the children, because we have seen a situation where some mothers will beat a child because the child has erected in the night. He's saying that he's a bad boy. Why should you be erect in the night? Because you are dreaming or you are thinking about some woman. So we have to know as scientists that it's a natural, normal physiological phenomenon which must happen with every normal, healthy man. We've said that it can happen even intrauterine. Intrauterine erection can happen intrauterine. And especially with the nocturnal penile tumescence from infancy up to old age. It can happen. If it doesn't happen, then it means that there's something wrong. But not that if it doesn't, if it has to happen 3 to 5 times, and you're only seeing it once, it doesn't mean that it hasn't happened in the night. And we're saying so because the only way you see it in the morning is that you have just come from an REM phase. And it's the REM phase of the sleep cycle that produces an erection. Okay. But the ones that you are asleep, you may not have seen them. That doesn't mean that doesn't happen in the night. I'm also telling you as a fact that these days, people's quality of sleep have been disturbed in a manner that they may not the line has started worrying me again. So if there are no questions, you can continue tomorrow. If you have any questions, can you bring them up? A lot of people have left already. Any question, please?
No questions for now.
No, okay. So see you tomorrow, okay?
Okay, Grandpa.
All right.
Thank you so much.
Good night.
Okay, see you, Grandpa.